Morning, everyone. My name is Hader Eid. I'm an MPH candidate in Epidemiology and Biostatistics here at CUNY SPH. Today I'm presenting my capstone research titled Bridging the Gap, Basic Pharmacy Access and Equity Analysis, Spatial Analysis of New York City Neighborhoods. First, I'm starting with a little bit of background on my research, then followed by methods and data sources, findings, and finally acknowledgement. As public health researcher Melody Goodman famously said, your zip code is a better predictor of your health than your genetic code. This really captures what we know about social determinants of health, that where you live matters tremendously. Pharmacy access is a critical piece of the puzzle. We know medication adherence depend on having convenient and accessible pharmacy services nearby. But low-income neighborhoods already face systemic barriers to health access. So the question becomes, are we also seeing spatial inequities in where pharmacies locate? During the background research, we found this paper of 2022, which was called Pharmacy Access, a Critical Lifeline for Equitable Emergency. It was found that pharmacies were responsible for over 50% of all COVID-19 vaccinations in the United States, averting over 1 million deaths, 8 million hospitalizations, and saving over $450 billion in healthcare costs. Areas with robust pharmacies presence recover faster, while pharmacy deserts in lower income neighborhoods experience worse outcomes. This makes pharmacy access a critical equity issue, especially during emergencies. This causal diagram evaluates the relationship between pharmacy access and healthcare outcomes. It also shows how socioeconomic and demographic factors such as poverty rate and ethnicity influence health outcomes through their impact on pharmacy access and healthcare infrastructure. Data from multiple sources, the 2022 American Survey for Neighborhood Demographics, the Census 2022 Boundaries, the Department of Health Pharmacy Distribution Dataset, which gave us the location of over 3,150 pharmacies across the city. We used ArcGIS Pro to map out where the pharmacies are and classify them according to whether it's chain, independent, or others. We also looked for statistical testing. We looked into it. We moved into R, where we ran several spatial analysis. This included average nearest neighborhood tests to see if pharmacies were clustering, Moran's 1 to test for spatial autocorrelation, and finally spatial regression models to quantify these patterns. The equity assessment was really the heart of this. We specifically examined whether pharmacy distribution was systemically different in high poverty neighborhoods versus low poverty neighborhoods, as well as looking into ethnic composition. I created this story map comparing 2019 and 2024 data pharmacy locations. Over 5 years, we're seeing significant closures, particularly affecting the independent pharmacies that serve higher poverty neighborhoods. This temporal analysis shows pharmacy deserts are actively forming in the communities that already have the least access. Our spatial equity findings make these closures even more alarming. Our analysis revealed 4 key findings about pharmacy inequity in the city. First, pharmacy clusters significantly. The nearest neighborhood analysis showed that pharmacies are only 160 meters apart on average, far less than the 460 meters we'd expect to find, with a z-score of -69. This clustering is extremely significant. Pharmacies are concentrating in areas while leaving gaps in others, which would later be identified as pharmacy deserts. Second, here is where the inequity becomes even clearer. We measured spatial clustering for both poverty and chain pharmacies. Poverty showed very strong clustering at 0.65, poor neighborhood clusters together, that's what it means, as do affluent ones. But chain pharmacies barely cluster at 0.078. That's an 8-to-1 difference. Poverty has a strong geographic pattern, but chain pharmacies aren't following it. They're not locating where the poverty is, in other words. Third, our spatial regression confirms this is systemic. It's not random. Chain pharmacies avoid neighborhoods with higher poverty and higher Hispanic population, while preferring neighborhoods with higher white population. Black population percent showed no relationship at all. even controlling for the fact that chains tend to cluster near each other. These demographic patterns remain highly significant. This isn't random market forces, it's systemic location bias. Finally, independent pharmacies are filling the gap chains are leaving behind. Chains operate in neighborhoods averaging 13% poverty and 42 white residents. Independents serve neighborhoods with 20% poverty and only 27% white resident difference of 6 and 15% point difference. Independent pharmacies are the safety net for underserved communities that chain corporation are systemically avoiding. So over here are some graphs to show you. This is the total pharmacy count with percent poverty. These are all the different pharmacy types, as you could see, and medically underserved area scores. And I made them into ranks, and then as you go further down the graph, it gets higher. So the white line represents the large chain pharmacy, the independent pharmacies. And over here is Hispanic population against number of pharmacies in New York City. Then the non-Hispanic Black. These are for all pharmacy type. And of course, this is the non-Hispanic White. Then we dug deeper to see each pharmacy type at a time. Once we excluded independent pharmacies, which are the backbone of New York City pharmacies, you could see that Hispanic population, the further you go down, the higher the population, Hispanic population, the less pharmacies they have. Same for non-Hispanic Black. Only in non-Hispanic White that once you take the independent pharmacies out, you could see that the higher the percentage of non-Hispanic White, the more pharmacies they're getting across all categories. If we looked only at large chain performance, we'd see that large chain pharmacies, according to percent poverty, the higher the poverty percent, the less number of large chain pharmacies they're getting. MUA, we only have one medical underserved category where there's a huge drop in large chain pharmacies. Hispanic population, you could see the sudden drop after the second rank. It gets steeper and steeper. Non-Hispanic Black, again, very obvious patterns here. Non-Hispanic White, you could see the steady incline of the increasing curve with the increased percentage. So to wrap up, this spatial analysis reveals systemic inequity in New York City distribution that has serious implications for public health and health equity. We found that pharmacies cluster significantly, but not where poverty clusters. Chain pharmacies systemically avoid high poverty and Hispanic neighborhoods while preferring wider and more affluent areas. Meanwhile, independent pharmacies are filling critical gaps in underserved communities, but as we saw in the story maps, these safety net pharmacies are closing at an alarming rate. This isn't just about convenience. Pharmacies' access directly impacts medication adherence, chronic disease management, and emergency response. When we lose pharmacies in already underserved neighborhoods, we're compounding existing healthcare disparities. Of course, this is my pharmacy team, as well as Professor Glyn Johnson, who helped a lot with this research paper. My research team included Mustafa Ali, Kimberly, Matthew, Vibhuti, Nang, and Mary Foot, a lot of great people who helped make this happen. Thank you so much.